Thank you very much, and welcome to the session called A Conversation with Insurance and Pharmaceutical Titans.
They changed the name.
I'd like you to meet the Titans. What I'll do is introduce, I think what we'd like to have here is a conversation. In the write-up of the book, it talks a lot about health reform, and I think everyone's talking a lot about health reform. What I thought we'd do with this session is start with a broader perspective because even though in Washington sometimes it seems like health reform is the only topic of conversation, when we're getting news alerts about the Senate's deliberation schedule from the New York Times and that they will or will not do something this week, I think we've kind of lost a little perspective. So what I thought I would do is introduce the panel and hear about some of the trends in the two industries that are represented here, the health insurance industry and then also the pharmaceutical industry. And there'll be time, clearly, to talk about the implications of health reform, and we'll certainly take a lot of questions with that. But I think it's important to understand that these organizations and these leaders actually run organizations every day and are undergoing transformation with or without health reform. So let me just introduce the panel, and then we'll start with Dr. Reed Tuckson. We'll make some opening remarks for us and kind of set the stage, and then I'll pose a few questions and then open it to you all to ask more. So we have a relatively small group in the audience. Thank you all for coming. So we'll hopefully get a lot of chance for dialogue rather than lots of formal presentations. So we're actually very pleased today to have three panelists here with us. The first is Dr. Reed Tuckson, here on the right. He is the Executive Vice President and Chief of Medical Affairs at United Health Group. And he's had a lot of incredibly important and interesting roles before that, from running Drew Medical Center and others, the District of Columbia. So he has seen the healthcare industry from many, many perspectives. And he'll start by kicking us off with some of his insights of where we are and where we're going. Next to him is Gregg, who's the Chief Executive Officer of Sigma Tau Pharmaceuticals. And he'll tell you more about what they do in a second, but they, in a nutshell, specialize in rare pharmaceuticals for rare conditions and diseases. We call it the neglected American diseases, or, they don't have a good name like neglected tropical disease, has a nice acronym in global health. We haven't quite come up with neglected rare American diseases. And finally, we have Mark Ganz, who runs Regents Health Plan, which has 3 million members. It's a nonprofit health plan with 3 million members across 4 states. Up in the Northwest, and he's a national leader, I think, in the industry and on healthcare issues in general. So I think we've got a tremendously, interesting and informed panel, and I think we should have a very good conversation. So with that, I'll turn it to Reed and ask him to give us some opening remarks and go from there.
Well, my challenge is to try to set as broad a context as possible so that you can fit in every possible conceivable point or question that you have and do all this in 10 minutes. And, by the way, irritate the hell out of you by going too fast. So we have to go beyond reform, and that's clearly the context of this session. We really need to get to the modernization of the health care and the modernization of the health and medical care system. And I make a distinction between those two, and we'll try to draw the context between them. I think at the end of the day, what companies like ours at United are focused on is how do we actually do this modernization? And we're focused first on the fundamentals. What's the purpose of our work, of our collective work together? What should be the purpose of all of us who are engaged in healthcare if we were to sort of put our activities together? What is it that we should be trying to achieve together? What is it that we are achieving together? Those are the big questions that I think about all the time, and I think that our company thinks about, and I hope that you think about. One way of thinking about that is, you've got your own definition. I sort of think about it as, how do we help each person to achieve their optimal health and well-being that's possible for them as individuals at each stage in their life. And so I sort of frame it in that way. I fully recognize the tensions between different stakeholders in the system. The challenge that we have today is, while being mature about the problems, how do we put as many of our differences aside so that we are working in harmony to achieve these larger purposes and transcendent values? How do we enhance the health and well-being of each individual person that's possible for them at each stage in their life? What's required to make this happen? Well, access to care is obviously important, but it is, at the end of the day, a small piece of the puzzle. Access to what? And how do we make that access available? How do we make it affordable? How do we make it sustainable? And how do we make it effective? And this is the challenge then for mature people and organizations. This is the challenge of expertise, the challenge of competence. Increasingly, it is the challenge of innovation, and it is also the challenge of investment of financial and human capital resources. There are very tough decisions that have to be made if we are, in fact, going to be able to make access to the right things available in a way that is affordable, sustainable, and effective. So let me quickly go through what I at least will give you as 6 essentials to focus on. First and foremost, I think now, is advancing a true patient-centered care delivery system. That is a rhetorical comment now. It's sort of blessed as mother, God, and country, but actually making it happen in an era where so many Americans, in fact, the majority of us, will be living with chronic disease, and those with chronic disease often and usually more than one. We are in the era of consumerism in healthcare. For the first time, we begin to experience the consumerism that is dominant in every other industry in America now coming into healthcare. This idea of who is the person that presents themselves to us, either for prevention of disease or management of disease. There is a new level of engagement with this person now, a new level of skills at being able to assess who are you, how do you think about health, how activated or empowered are you or are you not in being able to participate in the process of advancing your own health. What are your levels of accountability for the decisions that you make? Increasingly, no matter what happens in reform, individuals will be financially liable for so many more decisions than ever before. There's much more at stake. We will have the ability to advance this consumerism because of a plethora now of patient-specific data. Data and information that allows us to understand what's happening or not happening to the individual. And we will benefit, hopefully soon, with a new level of integration of health information technology assets that stitches together the ability to apply data in meaningful ways. I really, really am excited that David Blumenthal is in this role, but gosh, damn, we've lost a lot of time. And this is extremely frustrating to not be further along. Number 2, advancing prevention. I'm terrified about a tsunami that's about to happen. Think of it this way. We spend $400+ billion on cardiovascular disease today in America. $400+ billion. We've got tobacco, still 18%, very little progress over the last 15 years. Hypertension, undiagnosed or untreated to go at extraordinary rates. Cholesterol, undocumented or untreated to go at extraordinary rates. Obesity going through the roof. Diabetes going through the roof. I just gave you the risk factors for cardiovascular disease in a context where brilliant doctors are terrific in hospitals at saving you when you get your Fred Sanford moment. You know, Elizabeth, this is the big one. You get to the system, you will live. You used to die from congestive heart failure if you made it through the first step. Now, every anti-death drug known to man to get you through the congestive heart failure, people are going to be living forever, which means, of course, a zillion people needing to get a cardiac implantable defibrillator, and just play it all the way out. 400 billion headed to 400 trillion in a millisecond. And that ain't even on the discussion for the health reform. There's a tsunami about to take us over. So the population-based prevention is essential. And we are very engaged at how do you take the data around what's going on in communities and have communities deal with that information. How do you have a public conversation that's focused on the fundamental causes of death in our communities? That is not on the agenda. There is no mechanism, no back fence, no place to convene that conversation. So the health reform discussion is going on, but the idea of identifying what's happening right here in River City, how do we mobilize assets to deal with it from a community population base, And what we do not have is doodly squat worth of science that tells us what is the most effective, cost-effective way of mounting those programs. So elected officials are having to finance nice ideas. Thank God I'm on a personal mission for people to join Research America, the advocacy organization for science in the country. They've been terrific about NIH. They're all over trying to get more money for NIH. What I love about them, in addition to the NIH fight, they're trying to get some money for prevention. This is a fundamental. I want everybody to join Research America just because they fight in that fight. 1 penny of all the dollars in our health system goes for prevention research. We need innovation, new ideas. I love being a public health person. I was the Commissioner of Public Health in D.C. forever. I love the public health community. The problem with the public health community is they don't get to play with other boys and girls. They don't get access to innovation. So what happens is they get segregated out. So obesity. We were so frustrated about obesity. So we called up MIT and the Columbia Design Lab. Why? Because it just sounds interesting. They just seem weird. They know stuff that we don't know. They think about problems in ways that we don't think about problems. And I wish I had time to go into it, but what happens is they are helping us to approach food in a way that we would never have thought about it. So we need ideas and innovation on the prevention side. Individual prevention then becomes important. We've got to segregate the individual from the population with data, information. Who are you? What's your risk factors for disease? What are your individual risk factors for disease? How empowered are you? How do I give you information? I will tell you that we have learned that when we identify gaps in care, we can then fill those gaps by reaching out to that person and working with them. We've been able to do analysis on this. If this was being done by the Medicare system in the United States, over 10 years, the Medicare system would save $1 billion just in identifying gaps in care. And then, of course, being able to work with people to help them make better choices and decisions. Number 3, we've got to translate science into clinical guidance, better clinical care, and performance assessment. I think we all know that healthcare is inconsistent with the best evidence too large a percentage of time. Is that because doctors are bad? Of course not. No one in my medical school class fought to be last in the class. These are extremely competitive people. Darryl Kirsch will tell you from the AAMC that these folks are absolutely trying to do right, and our medical schools are trying to train them. But there is a lot of work that has to get done. We need more advocacy for research around clinical trials, clinical effectiveness, of course, and I will leave that clinical effectiveness research conversation maybe to the questions because I know it's always complex. We've got to confront the reality of waste. Tough decisions have to be made. What drives me nuts when I listen to this political debate in Washington, you get the sense that somehow or another, magically, no one will ever be angry or upset anymore if the government takes it all over. That the hard decisions will somehow be avoided. Folks, people are going to have to make very tough decisions about how we get after this waste of precious healthcare assets. And so I hope that what we're able to do is to get some money quickly into the hands of the specialty societies of our country. I think the stimulus dollars have got to go into the specialty societies to give them more tools and assets to teach their own folks, develop the guidance, and teach their folks how to do better quality. They are so underfinanced now that we are in deep trouble. Same for performance assessment. We are deeply involved with identifying the best performers for quality and effectiveness. It is very interesting to note, best quality doctors, most cost effective. Not going to the cheapest makes no sense. Best quality, you get the best effectiveness in terms of use of assets. The only way that we will have a culture in medicine today for that will happen is if we're able to get the profession to determine the performance measures. You can't have anybody impose those outside of the profession, so we have to do it. I got 1 minute left. Let me just do 2 quick ones last. In the interim, while we are trying to give dollars to the profession to change itself, we can't wait. There has to be medical management that is very aggressive. We have to get after things like preventable hospitalizations. We've learned that by having on-site nurse practitioners at nursing homes, you can really, really reduce the unnecessary and preventable hospitalizations coming out of the nursing home. If it was done at scale for the Medicare population, $166 billion over the next 10 years of savings. You hear what I said? $166 billion you can save. That's what we know how to do. This is not fooling around. This is running our business. We know if you extrapolate it. Transitional case management to decrease readmissions. You could save $55 billion over the next 10 years. Integrated medical management, including evidence-based criteria for whether or not somebody ought to be in the hospital or not, or whether they can be appropriately managed outside. That makes no sense to have somebody not be in a hospital when they should be, because it only costs money down the stream. Appropriate use, we know that we can ultimately, the savings in doing those things appropriately and intelligently is $100 billion over the next 10 years. And then using healthcare assets appropriately, particularly nuclear imaging, $13 billion over the next 10 years. Radiation therapeutics, $5 billion. And then reviewing claims for waste and fraud, $57 billion. Lastly, we've got to get at this idea of organizing and coordinating care and helping individuals manage their disease and giving them decision support guidance. We really now have learned a lot about how to help people navigate the fractionated delivery system and giving them information. Interestingly enough, people are catching on, even though this is still new. For example, you give people information about appropriate watchful waiting for when they have a choice between surgery or not surgery, and they really shouldn't have surgery. And you give them the right information, 12% of the time, just with information alone, they'll make the right choice and wait, according to the guidelines from the specialty societies. That's just with information. And then you can marry that with decision support coaching and counseling, and you begin to get there. I conclude with, I said 6, and I want to conclude with the 6th, which is administrative efficiency. Now, administrative efficiency is important. It is not nearly as important, given the kind of numbers I just threw out at you, than the clinical stuff. It's about 7 cents of the healthcare dollar is going towards administration and all the other stuff that has to do with insurance. 97% of it, of what's going on in healthcare, is on the clinical side. But there's still real savings here. And so we've got to find ways, and we are focused on driving data and transaction standards, elimination of manual processing, removal of unnecessary administrative intermediaries, payment accuracy reviews, and single-site credentialing are just some. The sum total of all of those together, writ throughout the size of the Medicare system, $300 and some billion over the next 10 years. So my point is, as I conclude, is there is a lot going on. But what we need to now have is scale, leverage, integration, coordination, and leadership. And somehow or another, we got to decide, even though right now the political conversation is about demonizing and pointing fingers, and of course, in anything, you got to have good guys and bad guys to get legislation through. But when all that foolishness is over with, adults are going to have to sit down together and say, how do we work at scale to be able to make this kind of a vision come true so that every single person gets the opportunity for maximum health and wellness for them at every stage of their life. And that only happens if everybody can decide to bury their hatchet in their self-interest and try to play together nice on behalf of the patient and not on themselves.
Thank you. So if we do that, then we're done. Okay.
It's easy.
We have 45 minutes. That's perfect. I'd like to turn a little bit to Gregg and then to Mark to hear their perspectives. And then I do want to bring us back to, I think Reed raised a lot of points about touching on different areas of how health insurance plays its role in the medical system, where the boundaries are, where the potential savings are. I mean, I think there's a huge amount of food for thought. But let's hold that one and let's hear about the pharmaceutical industry, kind of some trends, what Gregg sees, and then we'll come to Mark and then circle back.
Great. Well, thank you. I should say I'm sitting in between two insurance companies here as a pharmaceutical guy, and I'm a little uncomfortable because at the end of the day, they're the ones that pay for the medicines we develop. So I'm going to be very careful not to say anything offensive, and I don't think I will. What I'd like to do is
we're at Aspen. You can.
Exactly. What I'd like to do is maybe introduce you to a different view that you might have of the pharmaceutical industry as we talk about this issue of rare and neglected diseases. And so to do that, I'll tell you a little bit about what we do at Sigma Tau and some of the challenges we have going forward, and how, I think we might be kind of a microcosm of where we can go when we talk about personalized medicine and targeted therapies. And this all started for me in a way back in 1999. I was diagnosed with malignant melanoma. And as you know, you get the sort of first biopsy, and the doctor comes back and tells you, I've got bad news. You have melanoma. I didn't know much about melanoma at the time, but of course that's where the web and the internet is a very dangerous thing, because you can learn a lot quickly, and it's not always very uplifting. And one of the things that really shocked me during the time I was waiting for a definitive diagnosis, the staging of the disease, was that if I was at stage 4, I was probably going to die. I probably had about a 2% chance, and there was really nothing out there that could actually change that outcome. Now, lucky for me, I was diagnosed very early. A couple more stitches. They carved it out of me, and quite frankly, it was a little bit like maybe a little worse than a cold. So that was one of the very lucky ones. So that was in 1999. A few years later, in 2001, I had the opportunity to join this crazy Italian-owned company called Sigma-Tau Pharmaceuticals, owned in this miserable place in the world called Rome, where I'm actually stuck going to quite often. I know you feel bad for me. And in 2004, I found myself CEO and given the opportunity to sort of redirect where the company could go and some of the things that we could do to really change the course of disease for a limited number of patients in the world. And that melanoma experience really struck me. So we embarked on this kind of big idea that many would say is a really crazy idea, that can you build a sustainable economic model that looks at patients with very, very rare diseases and develops medicines and therapies that, for the most part, could be life-saving. And when I say rare, we have some medicines that treat 70 patients in the U.S., 100 patients. We have a product that we're developing called Sisteran eye drops. There's 300 patients in the U.S. We hope to finish it at the end of this year. It started at the NIH 20 years ago. And could you build a sustainable economic model around this? As an anecdote, we hope to submit for these Sisteran eye drops at the end of this year. And someone asked me to give you a distinction between sort of what we are and what you might think about pharma. Someone once said to me, geez, Gregg, if you get that drug approved and you launch it, what's your marketing plan? What's your launch plan for this drug? I said, well, I've been working on this for about 7 years. I know all the patients. I've met them all. I've met the families. And I'm pretty much just going to phone them up and tell them it's available. So I'm thinking a few phone calls and it's launched. So you get a sense that it's a very different model. So where we ended up today, we're a small group, 50 people, just outside of Washington, D.C. in Gaithersburg. And we have this crazy idea that we can focus exclusively on patients with very debilitating rare diseases. And we can do it in an economically sustainable way. One of the things that's always frustrated me about patients with rare diseases is society kind of says to them, look, there's only 100 of you or 200 of you. We could probably put a lot of resources there. We could probably develop a medicine that might save your life, but it would cost millions of dollars. And the price of that medicine would be so high, it would be unethical to charge you that much, so better that we don't do it. And this is what always frustrated me about kind of the charity model to some of these patients with very rare diseases. So we thought, well, can we change this? And to give you some context, I'll give you 2 examples of the types of things we work on. I call it the sort of traditional discovery development, and then what we refer to as search and rescue. So there's a disease that affects premature babies. These are babies born at less than 1,500 grams, and they can fit in the palm of your hands. And it's a disease called necrotizing enterocolitis. And it affects about 5,000 babies a year in the U.S. And in the past 30 years, there's been absolutely no improvement in outcomes for these kids. About 2,000 of them will die. And for those that survive NEC, it's a gastrointestinal infection that occurs in the NICU, because obviously they're born right into the NICU. We don't really know what causes it. And for those that don't die, they spend the rest of their life suffering from some very severe gastrointestinal disorders. So we had this crazy idea that no one really knows the cause of the disease, and no one's looked at it because the patient population is so small. It's premature babies. We had this crazy idea that maybe the disease is caused by the fact that they're born in a sterile environment, and like the rest of us, their stomachs don't get colonized with good bacteria, healthy bacteria. They're born sterile. Typically, they don't have a vaginal birth, so they're not colonized through that. So what if you could load them up with some really great bacteria, healthy bacteria, the day after they're born, and load them up with so much of it that they could develop sort of the defense against this gastrointestinal disease? Crazy idea. When we started it, people told us getting a probiotic approved as a drug product, health live bacteria, absolutely impossible. Figuring out which bacterial strains to use, impossible. There's no data out there. But undaunted, we moved forward. So that's sort of what I refer to as discovery and development. We're partnered with the NIH and the Neonatal Research Network on that. It's going to be a long process. We're 3 years into it. We have solved the first problem, which is can you make it? We did it a few weeks ago. We got our first clinical batch. We're now working with the FDA to get our IND approved. They want us to go into 20 healthy adults to at least show that you can digest this stuff without passing out, and then they're going to let us go into premature babies. So there's an example of, I mean, you can imagine the neonatologist. They have spent the last 30 years seeing this devastating disease in these kids and having nothing to do but load them up with massive antibiotics and nothing changing, no development, no discovery, nothing going on. Because let's face it, who cares about 2,000 kids with NEC? Well, we do. And we think there's a way to do this, despite the expense and the time and effort, in a way that is not charitable. It's economically sustainable. The other thing we look at is what I call search and rescue. There are drugs out there today that save the lives of a handful of patients. Cerebrotendinous xanthomatosis, call it CTX, a very devastating genetic disease. The patients will die of it without a drug called chenodeoxycholic acid. Well, CDCA was developed for the treatment of gallstone dissolution. It's long been replaced with better medicines. So at the end of the day, the medicine that treats gallstone dissolution actually saves the lives of these people with CTX. Who knew? There's 70 of them in the US, 100 in Europe, and a few others around the world. At the end of the day, there was only one company left who could make chenodeoxycholic acid. They were in Germany. A year and a half ago, they decided they were tired of doing this. It was too small, and they stopped making it. So this, for me, was huge. I interacted with some of the patients who went to the FDA. They were in panic. Imagine that you wake up one day, the drug that saves your life. Without it, you die. And it leads to neurodevelopmental problems, motor problems, eventually death. That you have, and you can live a normal life with the drug, will no longer be available. So one of the things we try and do is step in, say, can we grab that product, can we search the world and find someone else who can make it, find someone else who can make the active ingredient, the fill and finish, and continue to make it available for patients. Our problem is that chenodeoxycholic acid, it's not a big deal. It's probably going to cost us about $4 or $5 million. We actually flew over to Germany. We interacted with the company for the simple price of 1.2 million euros. They gave me the dossier, so I'd have all the original data supporting safety and manufacturing. We're looking now, and we think one of our sister companies in Spain can actually do the fill and finish. So, and we, at least through the negotiation, got them to make about 18 months more of inventory. So we're racing the clock here. But at the end of the day, the problem is that I'll spend $4 million. It's not a lot of money in the grand scheme of healthcare, but it's $4 million on 100 patients. So you can see a scenario where there's no way we can do this in a sustainable way without coming back to the market and saying, it's got to cost $10,000, $20,000. Today, the sales of that drug are $100,000 a year. There's no scenario where we can spend $4 million. This is a problem that we have to wrestle with. Ultimately, our necrotizing enterocolitis program, when we started it, we figured we had a 5% chance of success. Well, we spent a lot of money. We think we've solved the manufacturing problem. We're ready to move forward, and we think we're now at a 10% chance of success. So another $50 million, and who knows? But this is the challenge. If that product is successful, if we ultimately can change the course of NEC for these premature babies, there's no way to do it without prices that are high. And price has been the elephant in the room for a long time in our industry. And I guess what I'd like to show you today is it is true, it is an issue, but sometimes those prices aren't the worst thing. They're the thing that bring life-saving therapies to patients. Hopefully, we're actually, because it's near and dear to my heart, we're looking now at a malignant melanoma program in stage 4. It's a little daunting. It's a very difficult disease and very difficult to treat, but you never know. Maybe we'll come up with something. So part of what we do, as I say, it's very different than the traditional. I think that our model, our rare disease model, exclusively and only focused on small patient populations to bring them hope. And I'll tell you one thing, neat story. When we got that first vial back a few months ago, we found a company in Amsterdam that actually were crazy as we are and thought they could make this. And we went into the NIH and we met with the 18 neonatologists who formed the Neonatal Research Network who are going to help us on the development. And we passed the vial around the room. And, you know, we've talked a lot with them. We've had a lot of conference calls, face-to-face meetings. But I think it was the first moment where these neonatologists who struggle with this disease have to deliver these terrible results to parents. They held it. And I saw in that vial a level of hope that you cannot imagine. And so my concern in going forward is as we talk about healthcare reform and all the things that Reed mentioned, empowering patients, and can our model survive? Can we continue to do this? I have this fear, and there's lots going on, and who knows where it will end up. But I have this fear at the end of the day that what we do, we won't be able to do anymore. That we'll move into a period of time where patients with necrotizing enterocolitis or cerebrotendinous xanthomatosis, 100 patients who have a drug that can save their life and now it's gone, that there is no way that we can rescue these therapies. Well, this, for me, is one of my big concerns. I know there are challenges ahead. I know there are things we can do better. For me, we have to empower the FDA. The FDA treats patients, 100 patients with rare diseases, the same way they treat the next hypertensive drug in millions of patients. We have to go through the same hurdles. We have to do the same things. It's very frustrating. We have another product called Orbec for intestinal GVHD. It went to a panel. The panel eventually voted against it because of the question. The question was, do you have 2 phase 3 randomized controlled trials? No. There weren't enough patients. So the panel voted against it, and I was really frustrated. Someone on the advisory panel actually said, we can't have 2 standards. We have to have one standard for all patients. And the answer is absolutely not. When you have patients who have no hope, no therapy, you have to have a different standard. We have an option today to use the new REMS strategy that the FDA has to put pressure on us to say, okay, let's have some reasonable clinical trials that are cheaper, that can get the medicine to patients, but then charge us to develop patient access programs and patient registries. So I'm concerned about healthcare reform. I'm afraid of it. I lie awake at night worried about it, but I'm determined that through some of the things I heard, we can find a way to protect this rare disease big idea that we had, and that we can keep doing it, hopefully forever. And there's 7,000 rare diseases. There's only 330 drugs today, so we have a long way to go. Thank you.
Thanks. Well, you deserve the applause. I respect a leader who leads from his heart as opposed to from his mind. That means a lot. It must be a pleasure and a privilege to be an employee of your company and work with you. So I'm going to take a slightly different tack and just talk for a few minutes about what Regents is about, what we're doing. In the midst of the healthcare reform debate, in the midst of this very difficult economy, I could certainly talk about the broader issues, but I think Reed has captured that very well in terms of talking about the more global view. Perhaps it would be interesting to just talk about what one company is doing to just keep moving forward in the midst of this. Because one thing that I see in our industry is that there is one of the risks of global healthcare reform is that it leads to a certain level of paralysis because people start stepping back and waiting to see what's going to happen before they determine what their next move is, even as they're advocating for change in D.C. And I never believe that that's a particularly good strategy. I don't doubt that Reed does either, and it sounds like you certainly don't, Gregg. But when I had the opportunity to take over this company in about 6 years ago, we were in a very traditional Blue Cross Blue Shield company, not for profit, with a strong belief, a strong brand, a strong presence in our market. But we were in a lot of trouble, frankly, and had made a lot of poor decisions along the way, and a lot of those decisions were based on the fact that there was this ongoing belief that the things were just fine the way they are, and we should just continue doing what we've done for the last 30, 40 years, and that would be fine. When I came in, I looked at it and said, I don't think that's going to get us where we need to be, and frankly, I'm not sure that the people who work here really want to work with a company and in a system that is rapidly becoming a dinosaur in its current form. So we established I took about 12 people off site, and we spent about 10 weeks, 4 days a week, locked in a room, taking a full examination of ourselves and our industry, and saying, is this where we want to be? Is this what gets us up and out of bed in the morning, and do we find this fulfilling? And are we meeting the mission that we say we're meeting? What came from that was through a fairly intensive process, a very different sort of direction for us. And I'll just sum it up in what we call our cause, which has driven our company's activities, every activity, for the last 6 years. And it is simply this, that we will transform healthcare by eliminating the tyranny of healthcare, of waste, confusion, and threat for our members and their families. That is our vision. That is what drives our core strategies and has driven the activities of our company over the last 6 years. If you really listen to that, we will eliminate the tyranny of waste, confusion, and threat for our members and their families. It really doesn't speak to, kind of, if you will, to the left brain. It speaks more to the notion of that what we really have in this country in terms of the brokenness in healthcare is a cultural issue, and that we have to change the culture in the broader society, and also and start, those of us who work within healthcare, start with ourselves and our own culture in the way that we do business individually as well as how we interact with others in the system. So in a sense, you could say that our strategy, our vision as a company is to change the culture regarding healthcare in this country and start with ourselves and with the people that make up the Regents community, 3 million. What does that entail? We are, if I were to sum it up, just because of the limited time, I would say it is a fundamental paradigm shift from one of a system that is primarily focused on the institutions in healthcare and how they interact with one another and who's winning and who's losing amongst those various institutions. In short, health plans seek to control costs by controlling the behavior of others in the system through a series of financial incentives and sometimes just blunt force to try to meet what has been viewed as the commitment of the industry over time. And that needs to change. And all the players in the system need to change to one that is really focused on the person we're really here to serve, all of us, and that is the patient. Secondly, we need to move from what is primarily a transaction-driven business model to a relationship-driven business model. And Reed spoke to this in many of the gaps that he identified, is that there has been a lack of relationship with the patient and their families in the way that the healthcare system is set up. Third, it's a system that is just driven by control, a control paradigm, a control mentality from the perspective of how physicians interact with their patients. And I'm from a family of physicians, so I come by this observation from a direct view. But also companies like us and by many others who view that their job is to, in a sense, control what happens to people. And if you listen to a lot of the rhetoric around healthcare reform in this country, I would say if you just step back and listen, there's an awful lot of rhetoric that has to do with that. Well, we just got to get people to do this, or we need to. There's a sense that there's a we that knows how to take care of they. And that needs to change. Finally, it's a system that probably because of the control mentality is quite opaque. The average patient and their family, it's very difficult for them to get information around good information that they can use and actually work with on cost and quality, just for starters. And that the system, the people of those of us in the system need to work very hard on creating a much greater degree of transparency around those key elements so that we move from what is a relatively information-starved system that, at a useful level as opposed to just stuff out on the web to one that is much more information-rich, that helps people make decisions, different decisions. Our belief is that addressing those changes, starting with ourselves as a company, can go a long way toward moving down this road. And that hopefully that can be an example to those of our competitors in the marketplace, as well as those who we partner with. And I would say that over the last 6 years, we began to see real results. But I will tell you how difficult it is when you go to someone in our company, for example, who is a nurse who works in case management, who's spent most of her life making decisions about what kind of gates people are going to have to go through in order to get care. Because out of a sincere desire to try to help people help control cost, and you go to them and say, that's not your job anymore. Your job now is to be a facilitator for people to make straight the path through the healthcare maze, and that's why you're here. That's a huge cultural shift. And what's been great is that is exactly what happens today. And that is fairly countercultural at this point, although I would say that a lot of the conversation in the broader industry about integrated health management and coordination, Reed spoke to this, is the beginnings of what I see as the beginning of a cultural shift to realizing that our job is not to manage people. It's to help and facilitate their views so that they themselves make better decisions along the way of their care. And my personal belief is, with good information at the right time, that allow people to make those decisions, and it reaches not just to them as an individual patient, but also reaches to them, members of their family who help them in making those decisions, that people will make the right decisions. I simply don't believe the notion that people are bound to make bad decisions and costly decisions, and that somehow we have to control that. And if we can shift that cultural paradigm, then I think we can go a long way toward real transformation of healthcare in this country. We've seen it within our own, I'll just use one example of what we've done with our own employee base, is we decided that we were going to move from a company where, and I'll just tell you, when I took over the company, we had a lot of very, very unhealthy, obese people working for our company. Now, you think that's interesting? We're a healthcare company. Well, no. We actually were attracting, because of rich benefits and the like, we were attracting people to our company. And I had a lot of people who told me, we're so glad to be here. I plan to retire here because you have the best health benefits that money can buy. And it was all that I could do. I just chomped on my tongue because I wanted to say, don't get too comfortable. Because I really believe that people should be working for our company because they're there to serve others, and that's their primary motivation for coming and doing the work. And if they are here for that reason, of course we're going to provide, as a community, a good safety net around them. So one of the things that we did was we changed our benefit structure so that those who made the most in the company paid the most for their health care benefits. And so that started with me. And I pay well over 50% of our monthly premium. And it's a sliding scale going down to those who are on the front line and are the least salary. And there the company subsidizes 92%. They only pay about 8%. And what that did is it started with a cultural change at the top, because suddenly the top executives were paying a whole lot and really feeling what it felt like to have a significant amount of their income going to healthcare spending. And that started a different conversation in the company. One small move like that started changing culture. And then the conversations within the management team started to say, well, wait a minute, how can we really get at this and change the culture in our company from being kind of a sick-oriented company to one that really valued wellness? And then we started. And over the period of time, through a series of what I would say very strong incentives, a lot of fun, led right from the top, we have gone through a process of incredible move toward health in our company. And that has led to real results in terms of, for just an example, our workers' comp program. Our factor, if you will, if you're familiar with workers' comp, our factor for disability and sick has gone way down. Our absenteeism has gone way down. Productivity has gone way up. We measure through the Corporate Leadership Council, we measure ourselves against the very best companies in the country around employee engagement. Those scores have gone dramatically up on both what's called rational engagement and emotional engagement with the company and its cause. And we have seen the company is, I think, currently at about, I think we're between 18 and 20,000 pounds lost over the last 4 years. And we just track that as just for fun to see, and then we roll that back. The other thing is that it's really bent our trend in terms of healthcare spending. And when we did that, we turned those savings right back to employees so that they saw how their activity was changing. And it tells me that there's a lot of skepticism about wellness. And I think the reason there's been skepticism is because a lot of it has been sold on a programmatic basis. It's like, here, take this program and, And I know some companies, and there's one particular company, large global company that we are partnered with, they have a whole lot of wellness programs. That's part of the problem. It's not focused. It's not driven from the top. It's not part of their culture. And you have to drive it within the culture of an organization. So it can work. It's hard work. It's not something you can legislate directly to say, go do it. Although I do think, and we've been advocating for incentives, maybe perhaps tax incentives for organizations, so that they will be more, they'll have a reason, an incentive to focus on wellness and actually drive results. So I'll stop there, just enough to sort of tee up some discussion.
Perfect. Thank you very much. So, all right, now I'm going to live up to the other half of the title, which is a conversation. So that's where you guys come in. I think we've established that these gentlemen here are thought leaders in the field and are doing giving you incredibly different perspectives on kind of their thinking, their business model, how they see the industry, some of the challenges for health reform. So now I want to open it up to you. We've got plenty of time for questions, and go for it. Let's start here, and then we'll work our way back.
Understand what it costs to maintain their basic health care, and then you'd be able to promote a better doctor-patient relationship in that capacity. Because I feel as though patients don't necessarily, and to some extent, don't necessarily have a firm understanding of what it takes to be responsible for their own health care, and they would be more willing to buy in to the notion of health care and healthy living if they actually were consumers.
So first, I don't think our health insurance system is really an insurance system. It was founded in 1917. Actually, Regents, one of our predecessor companies, was the first health plan in the world. Started in the timber industry in Tacoma, Washington. And it was started because it was a year before the flu pandemic, interestingly. But it was started by a group of workers in the factories who were, it was a dangerous world there. People were getting their hands cut off in the sawmills, getting injured up in the mountains, cutting down trees. And one injury pretty much would mean financial destitution for their family. And it was as simple as a group of workers got together and said, this is terrible what's happening to Joe and his family. And if we could just take a little bit of our weekly wages and put it into a community fund, then maybe we could leverage that to help Joe and his family so that they don't become financially destitute. And then they went to the managers of the mill and they said, will you help sponsor this and help, can you manage the fund? And they said they would. And then together they went out to some local physicians and said, we don't have a lot of money here, but will you accept what we can pay you? And what you'll get for this is that we'll send all of our patients to you. That was the wellspring of what is our modern day healthcare system. Boy, how far we've moved away from that, because that was really on the paradigm. It wasn't about, okay, I'm paying my money, how much do I get? It was built on the paradigm of, I'm giving this so that others will be helped. I hate it, this pet peeve, when people talk about it's all about you. Healthcare is all about what you can get, and you should get more. No, I don't think it's about you. I think it's about a sense of community. It's about us. It's a community resource, but it's paid for by each one of our dollars, either directly or indirectly. So it is a very different model than auto insurance, although I would say you could learn some lessons from the notion of auto or other kinds of insurance, in the sense that, heck, I've been on an HSA program for myself and my family for the last 6 years. It is amazing how differently I interact with the healthcare system because of that, because I'm in an economic relationship with my physician. I ask different questions, and I got to tell you, I get some interference. So how much is it going to cost? Well, why does it care? Why do you care? It's covered.
Yeah, just the thesis of your question is perfect, though. And so what we see now is increasingly health benefit design is making that cost and that economics transparent to the consumer. So if you as a consumer decide that you're going to go get your health care at Little Sisters of the Saint elsewhere, even though their complication rates are much higher, their lengths of stay are inappropriate, then the person who's paying for that is going to say basically to you, fine, go ahead and make that decision, but that's on your economic pocket. The rest of us ain't paying for it. Similarly, new benefit designs and prevention. For example, diabetes. We have a very interesting diabetes health plan now that's catching a lot of steam, getting a lot of energy. And that basically is that if you do the right things in managing your diabetes, the economics for you are so favorable. So I think that you're starting to see that.
Right.
Good.
We'll go here.
Two questions. I love the story on probiotics with babies. Why don't we do that for adults who've gone on antibiotics for months, kill their total, colony in the tract, and then they have all these other problems. So, applause for you. Questions maybe for the insurance guys on transparency. My big idea would be to have the medical industry make a list of, here's my costs, here's my reinfection rates, here's my mortality rates, here's my average length of hospital stay for these procedures, and you base them on, from the toughest cases to the easiest cases. So then the common guy could walk in and go, Dr. Jones does 10 of these a year, Dr. Smith does 1,000 a year, here's his mortality numbers.
Yep. Batting average.
I know where to go.
Yeah, in fact, yeah.
We're doing it.
We're doing it. That's exactly it. Go ahead.
No,
Make your
go
point.
ahead, Reed.
No, we're doing that, absolutely. And the challenge, this is why I made the point.
Where do I
Second.
go to find that?
You go on, if you're fortunate enough to have one of our insurance products, that's the point of it.
Yeah, you go. Yeah.
Now, two things though. So that's the answer. Is you go on if you get our insurance, that's what happens. Now, two things very quick. One is, this is why I make the point so strongly that we've got to take some of those doggone stimulus dollars and pump them into the society so that the measures that we use are coming from the profession, and the measures that we use are the same ones that they use.
Yes.
Everybody uses the same measures. Do it one time. The other issue, the challenge, is, and it's so painful. You cannot inflict this easily on physicians. It has to come up from physicians, and they need support. The second thing is that the data that allows us to do it, though, needs to be even more robust, and that means we've got to pool the data around the common measures and pool the data through health information exchanges, so you can get to a statistical significance that is even more robust than today, and that's the next frontier. So that's where we are.
I would just add one thing. We're very late to this game. I mean, one of the interesting things is there's been for as much medical technology as there out there, consumer-based technology has really been behind. So there are a number of different ways you can get data along those lines. Say in Oregon, there's been a collaborative amongst health insurers, hospitals, governmental agencies, and the like to come together around under the auspices of what we call the Quality Corporation to develop, and in fact it was just launched, a website that has good cost and some beginning quality information. But we realized that it was best done in a collaborative sense. So to Reed's point, we have to replicate that across the entire country so that there is a sense of consistency around batting average and how it's reported, so that, because we're a mobile society.
Good question.
Go here and then in the back.
For Reed and for Mark, how much are you feeling yet pressure from your biggest customers, the employers, who make the decision on which group health plans they're going to buy or who they're going to have administer their self-insured plans, to do creative benefit designs, to have them be real health plans with differential co-payments based on going to low-cost, high-quality providers, all of that, or are most employers still, as I fear, fairly dumb about this and just managing this as an HR cost item rather than as a health and wellness program that they should be partnering with you on for their employees?
Yeah. Well, none of our customers are dumb.
Nor mine.
But I would say this: they're very tactical, and that's been part of the issue. I found that that we have better luck in the C-suite than we do in the human resources department. And unfortunately, the reality today is that the human resources departments are generally the ones that are buying and structuring the benefits. And a lot of times what they do is they're focused on a, kind of tactical, how much is the increase this year, or can I keep it down to a certain minimum? And where we've had better luck is where we've had the conversation with the CEO, CFO, and talk about what do they really want to, what are they trying to do? Because if they really want to bend their trend, then they have to lead it. It's not something that they can just say, oh, I'll just buy a program. You don't, because people are accustomed to a certain, if you will, cultural way of doing things, including their employees. And so they have to feel that they have to get the leadership from their own people they look up to in their organization. And for them to say, okay, I'll do it differently. I'll take this risk and go in a different direction than what I've been used to doing. And so I would say it's really when we develop a strong relationship and partnership that we get there. Otherwise, it's often very tactically driven, often consultant driven, and boy, consultants are all over the mark. They've got the latest and greatest that isn't necessarily well woven together.
The experience that we've had is, first, really, I cannot impress upon you enough how relentlessly afraid and frenetic the people who pay for health care are about what's happening to them. The economics of them trying to compete in a global environment with the economy today, they are so focused on the bottom line here. And they are expecting us, as a normal course of what we do, to ratchet out every ounce, every dollar of waste in that system and give it back. The people who I feel the most for are small business owners who have mortgaged their houses 2 and 3 times, who absolutely should not have to pay for those nuclear imaging stuff that was inappropriate, shouldn't have been ordered, and you got to drill with it. In terms of the innovation, there's about 25 large companies who are really clearly distinct from everyone else in terms of innovation, design, and are trying to really bring some real ideas to it. There's about 25, and they're basically Fortune 25 companies. They're big. They've got people on their staff who deal with these things. The rest of the market is pretty well focused on cost. Oh, by the way, we like that other new idea. Bake it into the design. So that's pretty much what our experience is.
If I could just add, so one comment in defense of the HR departments of the little guys. I'm on the board of Pharma, and one day we had a very interesting presentation on the impact of copays on drug compliance and on healthcare costs. And it was really interesting for me that actually copays can be a detriment to healthcare. And so, the way I am, I went flying back to the office and I said, well, here's what we're going to do as a company. We're going to have a plan that doesn't have a copay. So we'll fund this. If copays are a problem, if copays for some people maybe reduce compliance or then let's fix this. So I challenged my HR department. I said, go back to our insurer, and I want a plan that has no copay. They couldn't do it. They came back and said, we don't have such a plan. We can't do it. So I said, okay, that's okay. How about we'll just pay it? So when people have a copay, we'll pay it. Well, it turns out under HIPAA, that's really, really difficult. There's just no way to do it because you would have to actually ask your employees to tell you a little bit about their health care issues. So at the end of the day, here we are. We're, as a small company, very willing to address some of these issues that have to do with compliance and improving health care outcomes. Here's a scenario where I haven't seen, now maybe the product is out there, and this was just very recent, but we're willing to be flexible in that regard, and we're willing to think of different ways, but as a small organization, to help us define what that could really mean for us would be really interesting.
Talk to me afterwards.
I was going to say, it's called HSA.
Let's go to the far back row there. Blue shirt in the back row. Far back.
If I'm not mistaken, I think the industry is sort of opposed to the administration's plan, or a number of folks, at least on the Democratic side, plan to have the government compete in the insurance industry. My question is, just as a consumer, I'm a customer of yours. I think my premium's about $8,500 a year, and I think your CEO a couple years ago took $1.2 billion off the table. So
The thesis of your question in terms of the back end of it is one that I wish I could address here or had time to bore everybody to tears, but it's just not accurate what you said in terms of the economics of what you said, what he took off the table. And it's a very complicated thing over someone's salary over 15 years and well beyond just only the health insurance business. But I'm not going to try to defend that because it's just not appropriate to even do that. What you're asking me about at the end of the day is why is it that the insurance industry has been concerned about the public option? And the reason that they are concerned primarily is, number one, is that that people don't know what it entails yet and what the implications are. Most of what the public option has been talking about entails as a significant part of financing it, paying physicians at the rate of Medicare. If that happens, then it means that, first of all, no health plan could compete at that level of reimbursement to physicians. And what it also means is that physicians are screwed because at the end of the day, we are already subsidizing on the private side the reimbursement rates from public insurance. So at the end of the day, what it means is that the people who are in the private paying for health care are going to have to figure out a way to handle it, and they can't. And so there's a real concern. And those are the fundamental kinds of things that people are grappling with. It's not understanding what the implications will be. I think the other thing would be, and again, this is not to be debating those things because I have been fighting for universal access to health care for my entire career. I'm still fighting for it. I still want it. So there's not as much of an opposition as sometimes it is made to be. But what we're saying is that the things that I indicated today in my presentation, as quickly as I went through it, gave pretty significant bending of the curve stuff. So the private sector is doing the things that are necessary to be done. Whether we have reform or not, they're going to get done. We're going to do them on our side. So we just sort of think that at the end of the day, you need to be able to recognize that we don't want to have any of the tools taken out of our hands as we keep trying to bend the curve and do it appropriately. But we can talk about the other thing personally one-on-one.
I could just add one thing to that. One is that I think one thing that's true, and I'm happy about it, 3-4 years ago, some of the things that I was talking about around the table with both within the Blue Cross Blue Shield Association, we're all independent plans, but we meet regularly together and we try to work together on things to make things seamless across the country. And then America's Health Insurance Plans was some of the things I was advocating that were considered heresy in the boardroom of those organizations 3-4 years ago. But what I've seen over the last 3-4 years is there's been a significant shift in the leadership of the organizations over that time frame. It seems like always meeting somebody new. And with that new generation is very different thinking.
Yeah,
and so those who are cynical about what the insurance industry has put on the table in terms of healthcare reform and the notion of fundamentally shifting the business model away from one in which it's all about bumping risk and competing on the basis of who can shed risk and bump it to the other guy, and move to a true guarantee issue environment where it's truly that community model that really was the foundation of our company and of this system. That's real. That's not just political positioning.
That's true.
And so I think that that's good. On the other hand, if the American people, I don't think the evidence would suggest this, but if the American people say they want to go to a single-payer government approach and want to, say that the private industry is not the future, so be it. That's a decision that needs to be made. It needs to be made directly. What I think is difficult is where there is a belief, but there's a notion that we can get there on the installment plan. And I think that is a terribly wasteful use of American taxpayer dollars and frankly, will be a devil's bargain for patients. And so if that's where we want to go and there's a belief to do it, then let's just get on with it. And those of us who are currently in the roles we're in, we'll find something else to do that will be add value, hopefully, to human beings in this country.
I mean, if I could just give you a concrete example of this and why I fear this so-called public option. And I grew up in Canada, so I've got a sense of where this can go, and I've seen the underbelly and I've seen the good things. And just so all pharmaceutical companies, we support healthcare reform. We believe everybody should have affordable healthcare. But I talked about our search and rescue. We rescued a product years ago that was life-saving in Hodgkin's lymphoma. The product had been around since '69, and the cost of the product never changed since '69. it was about $15 for a course of therapy, chemotherapy, $15. So it took us 4 years to find someone who could make this product. We almost ran out. We were down to the last 400 bottles. So we finally got it relaunched around the world. We had to reprice this to recover our investment. So to show you the difference, in Europe, we had no hope of repricing it. Absolutely no hope. It wasn't even up for discussion. In Canada, I contacted them and said, here, and we gave the story of what we did, how we rescued it, the new manufacturing, the millions of dollars we spent. And they said, boy, we're really sympathetic, and we think you've done a great thing for the patients, but we're not accepting any price increases at this time. And I explained that it's $15 for a 14-day course of therapy. It's the bottle of water costs more than that. How can you not understand the issue? And they said, we understand it fully. We're not accepting it. In the U.S., do you know that under Medicaid, when you raise the price for drug beyond inflation, as of today, every time Medicaid uses that product, we pay them $1,000. It's an incredibly profitable product for them because the rebate exceeds what they pay. Do you know where we had no problem at all making sure patients had access to the drug? None. We explained it. Private insurance in the U.S. These guys right here, no problem at all. They understood. It was immediately covered. All patients had access. I mean, there's my fear in how this can play out.
What was the drug?
The drug was procarbazine. It's called matulane. It's actually a derivative of rocket fuel. And so you can understand the challenge in finding new manufacturing, and it's indicated for late-stage Hodgkin's lymphoma in about 800 patients.
So those of you who are levitating in the room, we now know.
www.sigmatau.com if you'd like to get your rocket fuel. Well, we are at the end of our time. I think you all can continue the conversation. I don't want to – Walter Isaacson is going to be interviewing Ron Williams down in the main session. I really would hate anyone to miss that, but please come up. I'd like to first thank the panelists for a great conversation.